everyone to this panel and this launch of the Palliative Care Report. It's a very dear to the hearts of the panelists here report, and they will tell you a little bit later about it. But before we start, if you have any questions during the panel or at the end, you can start sending it online through the app, or you can do it the old-fashioned way if you're here and raise your hand. For the people who are sitting in the back, you can take a chair at the tables if you want, unless if you're shy, but you're more than welcome to come forward. This panel is 45 minutes, so I'm not going to take long with my stories. I have so many stories about palliative care, but I'm sure you figured all the problems out. That's why you're coming with this report. I have with me Dr. Shafi Khan, Senior Consultant in Geriatrics in Qatar. I have Ms. Lubna Azzeddin, founder of Sanad in Lebanon, and Farah Dimashqi, Head of Quality Research and Development of Sanad in Lebanon, and Mahal Akoum, Head of Content at Wish Qatar. Without further ado, we start with Dr. Khan. Can you tell us about palliative, or you want to start with the launching of the report?
We're so happy.
Okay, yalla, we start with Ms. Lubna Azzeddin to launch the report officially.
Thank you, Rawa. Thank you everyone for coming, and the first and foremost thanks is to wish this amazing organization that is leading, Allahu Akbar, that is leading this beautiful work in the healthcare sector. This report that we are going to be launching today is a result of hard work among partners who have really worked hand in hand to make it happen. This report is entitled Integrating Palliative Care for Older Adults. It's a needs assessment for Hamad Medical Cooperation Geriatric Services. It's very important to first again thank WISH and the Ministry of Public Health, Hamad Medical Cooperation, ADI, Alzheimer Association, and WHPCA for their wonderful work together. It's been a year. We can't believe it's been a year. The details that we have come to work on and learn about the situation in Qatar and the adults in Qatar and the amazing work that's been done for Qatar, and the amazing also vision for palliative care for the elderly population in Qatar is just beautiful. I believe that this is the first step towards integrating palliative care and strategically and nationally bring it to the table in the forefront. So thank you, everyone.
Thank you for launching the report, but since you're holding the mic, we'll stick with you, and you'll tell us how Sanad worked with 5 countries in the region to work on this. Okay, so I will start talking about Sanad itself, so that for the ones who don't know about it. So we are, Sanad is a non-governmental, non-for-profit organization established in Lebanon to provide home hospice care for terminally ill patients who suffer from cancer mostly, till the very end of their lives in the sanctuary of their own home, free of charge. It was established in 2010, so it's been 12, almost 13 years already for Sanad. It's a small organization growing steadily and nicely, but as you can imagine, being in Lebanon, it's been a challenge for many organizations such as Sanad. In Sanad, we have 5 units. We have the medical unit, and we have the nursing unit, the mental health unit, and the quality research and development unit. And all those 4 units actually work together to make sure that the service is of excellent quality and that the collaboration is done in a way that ensures a patient-centered approach and, of course, takes into consideration equally the families of the patients. Coming to where we are today and working in the region, I just want to give a bit of context. So when we started in Lebanon, palliative care was not, as a service, was not acknowledged, or maybe was acknowledged on research level, but the service itself did not exist. So you can imagine the obstacles or the challenges that we were facing with healthcare providers or the community to understand, death and dying is not one of the most easiest topics to talk about. So a lot of awareness raising, a lot of education
for the healthcare providers and for the community was taking place throughout. Also, we went through COVID, which was another obstacle to make sure that you create a policy that ensures the safety of the patients and the workers at Senate at the same time. Also, the civil unrest, the issues that we've had that also hindered access to our patients. At the same time, which is what we are suffering now from, is the economic situation, to face it with grace and be able to continue to take care of our patients, the rising number of our patients. For the training and the region, going back to your question, so given all of this context, one of our Senate's strategic pillars, is to be a resource in palliative care and to help generate knowledge and to help train and improve work in palliative care in different countries. So we've developed through the Unit of Quality Research and Development, we developed our training material in medicine and nursing and in mental health to be able to either raise awareness or train specialists to start their own model. Through this, we have learned so much about the region, and we have learned about many mutual aspects that we all, we have cultural unity, if you like, but at the same time, there are differences that are specific to each country. So this was a very interesting journey. We trained countries like Sudan, Kuwait, Iraq, now Qatar, which we will talk more about it now. We just finished our training with the staff from the geriatric department with Rumaila, doctors and nurses and psychologists. So we have learned a lot, and we discovered, and happily discovered, if you like, that we speak a very similar language amongst us in the Arab world. And the specificities are, make it even, it's like you're painting something new. It's like you are it's like you're tailoring something for each specific needs. And so understanding the local cultures and addressing the concerns that maybe Ahl Qatar don't face it like Ahl Kuwait or Lebanon or Sudan, etc. So for us, it's also a learning curve, because we are learning what palliative care may mean in different countries, and that enriches the process a lot. It's also about our sustainability. The more work we do on our own quality, the more work we do in learning and understanding about other countries, it ensures our own sustainability in improving our work ourselves, and also sustaining Senate's operations in relationship with other organizations.
Thank you. Dr. Shafi Khan, can you tell us more about the status of the palliative care in Qatar, and where are we headed to?
Thank you so much. It's an honor to be sharing the panel today with experts and Ms. Maha from WISH. Really, I thank Dr. Hanadi Al-Hamad, the chairperson of the Department of Geriatrics, medical director of Rumaila QRI, and she is the national lead for healthy aging. Unfortunately, she could not be here today, but she sends her regards. Essentially, I thank Ms. Sultana, who has given this great opportunity today. I congratulate the team for launching this. It's a great moment in the history. It's like setting a stone. I congratulate WISH for such a beautiful conference. I'm sure I'm talking on behalf of all my colleagues. So going to the palliative care, in Qatar, we have a very well-established palliative care for cancer patients. We know globally that elderly people, the population, older people population is increasing. And this is due to various factors. This is due to the fact that we have excellent healthcare system, we have excellent staff. I've got a trainee who has joined in for the future. We have excellent resources. So with those, the longevity is increasing. As the longevity increases, the complexity of medical condition increases. You all share that thought with me. To the extent that we are facing debilitating illnesses on a daily basis. To be honest, we have expanded such hugely in the last, since the COVID time came, mashallah, Dr. Hanadi's, as a visionary leader, she took that opportunity to expand, to focus on providing excellent care for older people by looking at the continuum of care for the older people. So what I'm trying to say is to see whether the geriatricians can provide direct care to the older people wherever an older adult hits the healthcare system. For example, if it is emergency medicine, or if it is inpatients, or is it in the community, or it may be due in the ambulatory. So throughout this continuum, we have started to see some very complex cases. That's when, thanks to the National Health Strategy 2018-2022, which identified one of the priorities as healthy aging. Now, with this, Alhamdulillah, Dr. Hanadi is actually the national lead for healthy aging. It gave us an impetus to focus on one of the strategic goals, which says enhance end-of-life service. Now, thanks to Wish, who has open-heartedly supported us in this journey. Ms. Sultana, I have DY and Ms. Mamula from ADI, WHO, Ministry of Public Health, Her Excellency Dr. Hanan, Dr. Saleh Al-Marri, Dr. Huda, Dr. Binoy, all of them supported this initiative, and that's how we embarked on this journey. So essentially, as it stands, there is no palliative care for non-cancerous patients. So this is where all of us joined hands together to focus on and to try to see how we can work on it and try to see whether we can establish. And that's where Wish commissioned the Sanad team to step in and to do a detailed, systematic analysis of the current services and give us a report so that we can work on our next phase. So that's where we stand regarding the palliative current services.
Speaking of that report, Ms. Farah Dimashqi, you are part of the people who worked on this study. Can you tell us the most important findings of your study?
Thank you. First, it's been an honor to work on this project. Honestly, and as Lubna said, it has been a learning curve for everyone in the team, and put aside the relationship that we have created among all of us, we have new friends now. Thank you for joining us to know more about this report. So as Dr. Shafi said, we started last year in August, and we had put a plan to how are we going to assess what are the needs and what's the situation among older adults regarding palliative care. So we thought we do interviews with key informants, and we did 33 key informant interviews. This included interviews with frontliners, whether from different backgrounds, medical, nursing, and allied health professionals. We also did interviews with managers, and we also did interviews with senior leadership as well. We did interviews with different departments, including the geriatric department, rehabilitation, mental health, palliative care department at the oncology center in Hamad as well, in addition to other departments, and the home care services as well. So these were interviews with key informants. We also did a survey with patients and a survey with caregivers. We asked them about several aspects. The most important aspects we asked about was whether they know about palliative care or never or heard about it, their attitudes toward palliative care aspects. We asked them about their preferences and attitudes toward healthcare decision making, including knowing about their diagnosis, prognosis, etc. We also asked them about sensitive topics related to death and dying. We asked them where they would want to spend their last days in case they had severe illness. We also asked about some demographic information. We'll go through the results in a bit. We did as well a third step in the assessment, which is a survey with nurses and physicians at the geriatric department to assess the knowledge, the attitudes, and practices of the frontliners towards aspects related to palliative, death and dying, and dealing with older patients when it comes to the last phase of their lives. So that was the methodology. And we touched on different themes: the knowledge and the awareness about palliative among the three groups, the aspects related to truth-telling and healthcare decision-making, aspects related to death and dying, aspects related to access to and utilization of opioids, and aspects related to the needs of caregivers and patients during such a period of their lives. So we'll walk you through the main results, but just to give you a background on the number of patients and caregivers and their profile that we saw. We had 100 patients included in this assessment. 75% of them were females, and the mean age of them was 70 years, and 34% of the population was Qatari, and 43% of them were illiterate. We had a total of 102 caregivers. These were females, most of them, 71%. They had a mean age of 46 years, and half of them were Qatari, and 7% were illiterate. We also had a survey with 113 nurses and 18 physicians. So this is the demographic distribution of the participants who participated in the surveys. And the first theme that I would like to tell you about was the knowledge about palliative care. So we asked patients whether they have ever heard about palliative care. We gave them several options, and 96% of patients, they reported that they never heard of the concept of palliative care. 92% of the caregivers as well reported never hearing of palliative care. So we knew that they don't know about palliative care. So we asked them if they are in the last year of their lives and they had a severe illness, what would their main concerns and need and fears would be. The patients reported 4 main fears. Fear of pain was the main fear they reported. 35% reported this fear. 23% reported feeling burdened a burden on their family, and 18% reported fearing to lose their functionality and the ability to do their day-to-day activities, and 16% reported fearing being lonely. Interestingly, the caregivers, who are not always the caregivers of the patients, like they were not dyads, they might not be related, most of them were not related. So we had patients aside, caregivers aside, they weren't the relatives of each other. Despite that, caregivers' insight on patients' need was very similar. The top priority needs were as well very similar. So caregivers as well reported that their patient would have these fears and concerns, the same ones that the patients reported. And then we moved to ask them if these are the fears and concerns, what might the needs be? So what are your needs in case you had a severe illness during the last year of your life? And they also they reported 4 main needs. 47% reported the need for psychological support, mental health support. 40% reported the need for having 24/7 access to healthcare professional support, either by phone or through home visits. And 29.5% reported the need for having their symptoms controlled, pain or other symptoms. And 22% reported the need for spiritual support during such a phase. Interestingly as well, caregivers reported similar needs, reported their perceptions about the patient's needs. They were similar to what patients said as well. We also wanted to know what would the caregiver needs be if they wanted to care for these patients during the last year of their life. And something to highlight, that these patients, most of the major medical problems that they reported, like we asked about what do they have now currently in terms of medical problems, the most common reported problems were diabetes, hypertension, and chronic artery disease. So the caregivers talked about their needs, and this was also a multiple choice question. And when we asked them, the 4 main needs reported by them was, first, having access to healthcare professionals to support them throughout the process, either through phone or through home visits, and 54% reported this need. Interestingly as well, 44% of caregivers reported the need for psychological support to care for the patients. So they want to be supported so that they are able to care for the patients during this period of time. And 15% reported the need for social support, and 35% reported the need for having access to equipment and medical supplies at home so that they are able to better care for the patients. Similarly, when we asked patients about their caregivers' needs, they reported similar needs, however, with different percentages, but the needs were the same. So that was the perception of patients and caregivers about their needs in case of a severe illness during the last year of life. There was a major theme in the assessment that we wanted to highlight on, so that we start from, so if 45% of patients are reporting the need for psychological support, it means this is a need, and knowing that this is a need that they are foreseeing in the future. Like, the need might be even higher when they are put in such a scenario or situation, when they are nearing the last stage of their life as well. A second theme we wanted to highlight on, and we know it is a controversial theme, is truth-telling and healthcare decision-making in healthcare in the Arab world, in the MENA region. And we've asked about several aspects. We asked patients whether they want to know about their diagnosis and prognosis. All patients, 100% of them, said they want to know about their diagnosis and their treatment options. 99% of them said they want to know about their prognosis and how is their disease evolving. And 93% said that they want to have the final say in their decision making that is related to their health decisions. We asked caregivers as well, what do they think about patients knowing about their diagnosis, prognosis, and being part in the decision making. Interestingly as well, they also agree to a lesser extent, but the majority do agree as well. So caregivers, 78% believe that patients should know about their diagnosis. 86% believe that patients should know about their prognosis, and 65% believe that patients should have the right to have the final say in their healthcare decision making. We then moved to the discussions about aggressive treatment and resuscitation measures and CPR, and we asked about, and here the percentages started to decrease. So when we shifted the talk to aggressive treatment, patients, some of them wanted to have say in taking such decisions and to resort to not going for CPR or aggressive treatment. However, the percentage was lower than compared when we talked about knowing about their diagnosis, prognosis, etc. So 57% of patients agreed that they have the right to refuse medical treatment in matters of life and death. And 55% agreed that in case of severe illness and when there is no cure, that they have the right to refuse CPR when an arrest happens. And caregivers as well, the lower percentage than the previous percentages agreed to these measures. So here we the aspects that are related to the cultural and whether families, like even in the discussion when we discussed with the healthcare professionals and when we did the interviews with nurses and physicians, and we asked them what happens usually when it comes to truth-telling, what happens usually when you want to discuss aggressive measures and you want the family, you want to take a decision related to whether you put the patient on a ventilator or you go for resuscitation or not. A lot of factors and challenges that are related to cultural factors, religious misconceptions, aspects related to families feeling that afraid of feeling guilty or burdened to take such decisions because they want to do the maximum that anything can be done, and in their minds this is the maximum, so anything can be done is better than nothing. So all these factors play a role in families taking decisions on behalf of patients to protect them, because they also think that patients would do worse if they know what's going on, and this would psychologically affect their well-being and would alter their progression negatively, of course. So families are trying to be protective to protect their patient because they know better how would their patient react to such discussions. However, on the other hand, they want to feel that they have done everything they can do for their patient, and they don't want to feel guilty that what if I took this, I did not do this step or I did this step. So all comes from doing the best for the patient, but on the other hand, aggressive treatments are as well a source of suffering for patients, and the over-medicalization of health, especially in the dying phase, has pushed the healthcare system to move towards aggressive treatment. Now, the healthcare professionals are moving backward to what was before, to allow patients to not to suffer during this phase, especially when these measures are not effective and they are futile and they will not lead to reversing the original problem and issue. So these were the main ideas that were coming up from the interviews with the healthcare professionals. And from the survey, from asking caregivers and patients about their opinion towards such aspects. On the other hand, when we did the survey with the healthcare professionals, they had positive attitudes toward telling the patient about their diagnosis and prognosis and allowing patients to take decisions. However, these challenges that we spoke about were hindering this practice. We also talked about a very sensitive topic, which is death and dying, and where would they want to spend the last days of their life if they had a severe illness and they were approaching the life. And we asked patients, caregivers, healthcare professionals as well. We asked patients, where would you like to spend your last days? And a very big percentage, 87% of patients would want to spend their last days with their family at home if they are supported by healthcare professionals at home. So they want to be surrounded by their families till the very last moment. Caregivers as well think that patients would want to stay at home, and 85% as well think that their patient want to stay at home, and they want their patient to stay at home as well if they have the adequate support at home to stay at home. Similarly, nurses and physicians, 81% and 79%, believe that patients want to stay at home if they have the chance to do that and if they have the support to do that. So everyone is aligned in this as well. And according to literature, most patients want to stay at home if they have the resources and the support and the ability to stay at home, if there's someone to guide them throughout this phase as well. Another topic that we touched upon was access to and use of opioids, because in palliative, use of opioids is very important in hospital settings and home setting in order to be able to control symptoms as much as possible, especially pain and other symptoms such as breathlessness. And we know that there are a lot of barriers usually worldwide, in the Arab world and worldwide, regarding access to opioids. So this is why it was an important theme for us to touch upon. We have asked, we know that in hospital settings, all forms of opioids are available in Qatar, and of course, as in hospital setting, you can give any form of opioid, whether oral, IV, subcutaneous. There are no restrictions in this, of course. The main challenge was that the availability, the ability to prescribe IV or subcutaneous morphine or opioids in general at home care settings, and this is an issue in most of the MENA region. The restrictive use, the restriction and the policies about how to use opioids in home care settings. This is one of the aspects that in the future the HMC will be working on in order to allow for a home hospice services to be available and to provide the services to the patients in a full-fledged form. We also asked families about whether they think opioids, specifically morphine, is linked to death, or whether they would link it to death if their patient is receiving morphine. The good thing is that many of them said that they don't know, they don't have neither positive nor negative attitude toward this, and this is even better, like not knowing is good. a very low percentage, the lower percentage thought that yes, morphine is associated with death. So these were the very main findings of the report, and based on the report and the needs assessment, we recommended different recommendations at different levels. At the policy level, talking about challenges and to further develop and progress palliative care in Qatar, a national strategy is a very important step to take in order to further progress palliative care in Qatar. A national strategy that touches on the service provision for cancer and non-cancer, for vulnerable populations as well, for adults and for children, that touches on education, research, awareness raising, and advocacy. In addition, this exercise and the main aim of this exercise was to recommend to the geriatric department what kind of services they can start, specifically what kind of palliative care models they need to adopt, and so that they are able to provide palliative care for the non-cancer geriatric population. And the report highlights 4 main models: a palliative care consultation team, which is known as a mobile team that can see patients and get consulted on patients who need palliative care, a palliative care unit that can admit patients to its own beds, where patients have more complex needs and require continuous palliative care service or skills by staff who are specifically trained in this. A palliative care home-based palliative care service, because obviously the report and the need assessment highlight the huge need for home services where patients would like to stay, and hence similar to international studies as well, providing this is now a need, and we need to fulfill it so that we are able to better care for these patients. And lastly, we recommended a palliative care clinic where patients who are better off and not too advanced in their disease stage are able to visit a palliative care physician at a clinic and to follow up with them. That was the recommendations at the service level at the geriatric hospital, and of course later on the integration of palliative care is recommended for any condition, regardless, at the heart hospital, for example, at the internal medicine department. So any patient who have palliative care needs, who have suffering because of their illness, are eligible to receive palliative care. Of course, at the education level, so that they are able to provide this service, we have recommended 2 types of training. Training that addresses primary teams, who we call usually generalist teams, who are able to provide a basic set of skills of palliative care to their patients as part of their routine day-to-day care that they provide. However, these teams need to be supported by specialized teams who are specialized in palliative care, and who will be providing the services at the models that were suggested at the PC unit, or as part of the team, or as part of the clinic or the home palliative team. So these are the specialized ones who will support the primary teams in providing primary care for their patients. However, will take care of the more complex cases and the patients who have more complex needs. So 2 types of training, specialized and generalist, and definitely as part of the national strategic plan to integrate palliative care in the undergraduate curricula of all healthcare professionals, not only the nursing and the medical, as well as also the allied healthcare professionals, whether it's psychologists or social work or pharmacy or physiotherapy. And the assessment also highlighted the need for spiritual and religious leaders who can be part of the palliative care team, who need to be part of the palliative care to support patients, because this is a major issue or a major aspect that need to be covered during palliative care, the spiritual aspect. And one of the questions of the needs assessment was whether they need spiritual support, and more than 80% of the patients reported that they would want spiritual support during the last phase of their life. So however, this will require as well integrating spiritual counseling or spiritual slash the role of this person into education, the undergraduate and the graduate as well, and later on to be able to have such persons available on the teams to provide such support. The last two recommendations were one at the awareness level and raising the awareness of the community and the healthcare professionals as well in regard to palliative care. In general, this should be in parallel with whatever work is being done. However, the services need to be present before doing such campaigns to make sure that if patients want to resort to a service, that the service is available. And the recommendation was based on what were the main needs of the patients reported. So we knew that there are issues related to truth telling, and patients want to know about that. Issues related to aggressive treatment and how to approach this discussion with patients and families. So the awareness campaign need to address these aspects and need to tackle what are the main challenges and present to the community what are the benefits of not going to aggressive treatment and what is the standpoint of religion on this as well, because it is supportive to foregoing aggressive measures during the last phases of life, especially when it's not reversible and it's futile. So all these together will help families and communities be more accepting of palliative care and hence allow them to accept the service and take it. Lastly, because we know that very briefly, 1 minute. Lastly, because we know palliative care cannot happen without the support of the families and the caregivers specifically, and the community in large. There was this recommendation on this aspect specifically, and because we know that patients cannot die at home unless they are supported by their families and their caregivers, special attention needs to be given to this segment specifically, and supporting their needs, their awareness, how to take care of their patient, providing 24/7 support to them, and lastly, to build a social network that talks about death and dying and bereavement after death and dying of the beloved one in a more open way, and to break the taboos about talking about death and dying, so this community is able to support its patients and to move back to the good old days where patients used to die at home, supported by their neighbors and families and friends. Thank you.
Thank you, Farah. But before I pass to Maha, I would like to ask if we can put more lights because we're getting sleepy and there's no presentation anyway on this. Maha, Wish has been a long advocate of palliative care, so tell us what you've done so far, so briefly also, so we can leave the door for questions.
Thank you, Farah. We're going to quiz you on all those statistics later, so I hope everyone is paying attention. It's great to see so many faces. First of all, this was originally, this launch was supposed to take place online over a webinar, so I'm really happy things ended up this way. Yes, indeed, Wish has been a long-term advocate of palliative care. We were inaugurated, for those who don't know, we first started working in 2013, and in the first summit in 2013, we actually published a report on end-of-life care. So it's been with us since the very beginning. And then sort of 5 years down the line, we thought after, becoming more established and speaking to more physicians and members of the community, we started to understand sort of the gaps in services that are here in Qatar, and the need for us to look into this from a religious standpoint as well. We have an Islamic ethics theme that runs throughout all of our summits. So all of our summits, we'll have one topic that focuses on a healthcare issue from an Islamic angle. So, and a lot of the issues that came up in the conversations with the patients and physicians alike were issues that had a religious background to them or religious relevance. And a lot, so we would talk to patients who, or caregivers who had patients on life support for over 20 years, not knowing whether whether it was actually permissible Islamically to remove life-sustaining support. So All of this culminated in the launch of the Islamic Ethics and Palliative Care Report in the year 2018. And from there, several things. It was a snowball effect. We worked with Georgetown University and Archbishop Paglia and the Pontifical Academy for Life. In early 2019, we signed a Doha Declaration on palliative care that brought together the Catholic religion viewpoints as well as the Islamic religion viewpoints on several issues such as artificial hydration and nutrition and the communication of bad news and on all of the lovely things that Farah just mentioned. But then later that year we visited the Vatican, and again we did the same thing. We reiterated all of these learnings and recommitted to working in the field. And shortly after that, I mean, this report has been 1 year in the making, but it's really been 2 years preparing for it. Me and Duai have been working very closely together with Alzheimer's Disease International. So it's really been the work of 2 years. So from there, we started working with Sanad, who have been phenomenal, both from the research needs assessment point of view as well as the training. So based on these recommendations, we put together also a small brochure that made the recommendations from the WISH report sort of more accessible to patients and physicians, and that was launched in November last year. And then we started working towards the training this year and publishing of this report. So it's been a very long journey, but a very sort of fulfilling journey, and I'm so grateful to have made new friends and to have come a long way. So obviously this will only, research means nothing if it's just published and it's sitting there. So we look forward to implementing and changing policies in Qatar, whether that means a new national strategy or working with Sanad on future trainings as well.
So does anyone have any question so far quickly? We have 5 minutes. I have one question very quickly to Lubna, in case no one has it. I go for it. I go for my question. Okay. Lubna, there's a lot of stigma around palliative care. A lot of people, as Maha mentioned, still think that maybe letting them die at home means, again, going against God will. It's a big dilemma we face when we are caring for an elderly. Should we sustain? Should we not sustain? And so on. Can you give us examples of awareness campaigns that proved to be successful so far in advocating and educating more about palliative care?
Sure. Like any change in mindsets, you need time and accumulation of work. It never happens overnight, obviously. So a lot of work in parallel was taking place. On the community level, we were running awareness raising activities with different stakeholders, with different partners at university levels, at houses of worship, at organizations, etc., to create a discussion around the topic. Death and dying is not something that people are usually happy to discuss, although it is the only clear truth. We can't argue about death and dying happening. So, and you work on your target groups on different types of languages and different types of communications that addresses their own concerns and fears, because we don't want people to think that palliative care is about ending somebody's life. It is absolutely not. But understanding the concept, people don't listen or don't grasp the idea too quickly. So repetition and continuity and accumulation is a huge part of any awareness raising. On the healthcare providers level, we also had many different lectures with doctors, nurses, university hospitals, different private hospitals, public hospitals, far and wide. We didn't want to stick to the elite, because those know and those have read and are acquainted. But you do want to reach out. And we have noticed in Sanad that the amount of referrals, the difference between the referrals that used to come in the first 5 years as opposed to the last 7 years are very different. Now the referrals from doctors and by doctors is much, much higher. And now the word palliative care, رعاية تلطيفية, is a familiar word. It doesn't have to be, people don't have to have a full WHO definition in their minds, yeah? We don't expect that. But we do know that it's become familiar. Old age? No, cancer. What was it? This alone tells you that it's become floating in our space. And that means you are actually putting it on the map. And it has become a choice in Lebanon. And that we are so proud of. It has become a choice. And so now people have reactions. Oh, we took him to a palliative care department. It's a word that is used with maybe trust as well. So a very long answer to say it takes time.
Takes time. You have very, 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 very quick question because I have to run also for another panel. So one.
I wanted to say is an observation. Reading the report, which I had the privilege of reading before it was coming out, I realized that it's global impact. So this is not, I'm really super grateful that this has come out. I followed the conversation here from 2019 when you launched a report then with the Vatican. I mean, these are issues that are of global interest, and there is a lot about helping families. I've had to go through it myself as well, so reading the report was actually really difficult for me. But I think there is a vast, we were talking earlier with one of your attendees about the fact that this conference shows how Qatar now can be trailblazing. In this instance, you've really been trailblazing, and you should be sharing this with a much wider group of people. So we are very fortunate to have been associated with it.
Just quickly, just wanted to touch upon a point with it. I work with people who have Alzheimer's and other dementias, and one of the big challenges are people who go for PEGS tubes, so internal feeding. So I come across people who would live for 8 years going through the end of life stages. Basically, they are like mummies. They are fed, but there's no quality of life. And the big challenge we come across is something that you highlighted, the religious aspect, because people feel it's unkind to deprive them from food, and because that will lead to death. But at the same time, I think there is this element of less education about other ways of kind of slow hydration and maintaining the person. And we all believe in the A'mal billah subhanahu wa ta'ala. God only can tell when someone will die, but no quality of life and very prolonged pain for the family as well, because you could see some of them, they don't want to give up basically. So the impact is on everybody.
Thank you very much. Thank you very much for this love. I'm sorry, there's no more time. I really have to run. You can stay and discuss. You are more than welcome to stay and discuss, but I have to close the panel. You are free. This is what Wish is for. It's for people to keep the discussion going beyond the panel. So I'm sorry that I have to close the panel. Thank you very much, Dr. Lubna Azzeddin, Farah Damashqiya, Dr. Shafi Khan, and Maha Al-Akoum for this. And enjoy the conversation. Keep talking about it. Thank you.